Hello, and welcome to my presentation on post-traumatic stress disorder. My name is Matt Storie, and if you'll follow along in the PowerPoint that I included, the media will be easier to view for you. So let's get started by examining the history and development of post-traumatic stress disorder. So the psychological changes that exposure to trauma have on people has been known and recorded since ancient times. However, for most of human history, much of the focus on how trauma impacts the human mind has been centered around war veterans. So the first time that the medical community and the scientific community addressed the psychological impacts of traumatic events in war on a large scale publicly occurred in the 1860s and 1870s after more closely examining the veterans of the U.S. Civil War and the Franco-Prussian War. So the first real model that came out for post-traumatic stress, well, what would eventually become post-traumatic stress disorder, was called soldier's heart. And the doctor who described it said that the symptoms were cardiac in nature. And aside from anxiety, no psychological symptoms were listed, except for anxiety. They were the physiological symptoms that we see today in PTSD, such as elevated heart rate, shortness of breath, trouble breathing, things like that. Dr. Jacob Mendez da Costa of the United States developed this theory while studying veterans of the United States Civil War, and was also sometimes called da Costa's syndrome. And it was treated by sedatives to suppress the rapid heartbeat and shortness of breath. So that theory prevailed primarily until World War I occurred, when a larger amount of soldiers were coming home with horrible PTSD and were able to be studied on a much larger scale. Additionally, the field of psychology itself had progressed quite a bit in that amount of time, and the new prevailing theory was called shell shock. The shell shock model thought that the psychological and physiological damage that soldiers showed was due to some sort of underlying brain damage that was not yet identified, that was caused by constant exposure to large explosions. However, towards the end of the war, this began to kind of fall apart and be questioned more heavily because scientists were finding that veterans who were in combat situations, who were not exposed to heavy explosions, were still coming back with some of the same symptoms. Shell shock theory described the symptoms of soldier's heart, like before, but now it also recognized episodes of panic and anxiety and paranoia that individuals with post-traumatic stress disorder exhibit. By World War II, the shell shock theory was replaced by a new model that was called the combat stress reaction, or CSR, and was primarily developed in the United States of America. And combat stress reaction was taken a lot more seriously by the medical community. Up until this point, post-traumatic stress disorder was seen as a sign of weakness in people who came home, and there was heavy stigma associated with it. This continued at to some degree amongst quite a bit of the population, going as far as Lieutenant General George Patton publicly declared that he didn't even believe combat stress reaction existed. However, the medical community considered it to be very real and very serious, so serious in fact that as much as half of the United States soldiers discharged amidst World War II were discharged because of combat stress reaction. The combat stress reaction now detailed the previous symptoms that shell shock theory did, but it now also included the physiological, psychological, and mental exhaustion and social exhaustion that soldiers displayed after they had returned home from combat. And this was now treated, not with sedatives, but with hydrotherapy, which were various forms of hot baths and soaking in mineral water, things like that, primitive forms of electrotherapy, and encouraging calm, quiet lifestyles that were limited in excitement. PTSD, as we know it today, was first made publicly known in a widespread manner with the first edition of the Diagnostic and Statistical Manual of Mental Disorders, published in 1951. Now, instead of combat stress reaction, the condition was called gross stress reaction, and it was significantly different because it recognized that it could occur in any individual who experienced a significant traumatic event, not just in soldiers. And it showed many of the symptoms that combat stress reaction does. As more research came out and psychology itself was better understood with the continued publications of the Diagnostic and Statistical Manual of Mental Disorders, it slowly developed into the disorder that we know as post-traumatic stress disorder today. It was first called that in the 3rd edition, and in the 5th edition, it moved from being an anxiety disorder to now, as it is considered, a trauma disorder. So, what exactly is PTSD? Well, it's a bit of a complicated disorder, so I'm going to run through the criteria that are listed in the DSM-5, and then we'll do a more easily understood summary. So the first criterion is the presence of a stressor. Some sort of traumatic event or events had to have taken place in your life. You could have either been subject to the traumatic event, witnessed it happen to somebody else, or hear details of a traumatic event happen to a close loved one. Criterion B for post-traumatic stress disorder are intrusion symptoms, and this criterion is detailed as having one or more of the following occur after the traumatic events have occurred. Having recurrent and intrusive memories about the event, having dissociative feelings where you feel like you are witnessing or part of the traumatic event when you're having these recurring memories, having nightmares and recurring dreams that are distressing about the event, and intense or prolonged psychological distress at reminders or memories. Okay. Criterion B for post-traumatic stress disorder are the presence of intrusion symptoms. This criterion is met when one or more of the following occur after the traumatic events have happened to the individual. Having intrusive memories to the traumatic event, recalling them, having dissociative feelings and feeling as if you are either witnessing or part of the traumatic event as you're recalling it, memory cues that remind you of the traumatic event that caused you intense or prolonged psychological discomfort, marked physiological reactions, rapid heartbeat, sweating, a fight or flight response, triggered by some of these cues that remind you of the traumatic event, and also recurrent and very distressing dreams about the traumatic event. All of these constitute as intrusion symptoms. Criterion C are avoidance symptoms. Criterion C are avoidance symptoms. Criterion C are avoidance symptoms, and criterion C is met when persistent efforts to avoid things associated with the trauma or that remind you of the trauma occur consistently over time, and it is met when either one of these two are fulfilled, or both. Avoidance or efforts to avoid distressing memories, thoughts, or feelings about closely associated with the traumatic events, or avoidance or efforts to avoid external reminders. These are the cues that we were talking about. These could be people, places, objects, any sort of thing that triggers that memory in your mind. Being avoidant of all of these would fulfill the criterion for having avoidance symptoms. Criterion D are mood symptoms, and this is probably the easiest met criterion because there are so many different possible symptoms that could occur, and many individuals with post-traumatic stress disorder experience several of them. We have impaired memory of the traumatic events, or having distorted logic applied to them, feeling like you might be to blame or something else might be to blame that was not related to the trauma or is otherwise unreasonable, but that distorted memory, not being able to recall specific or important parts of the trauma, or reasoning associated with it, both of those would constitute having mood symptoms. Persistent and exaggerated negative beliefs about oneself, that's going back to the blaming yourself, but a bit more isolated. Persistent negative emotional state, experiencing fear, sadness, distress, or hopelessness. The inability to feel happiness or other positive emotions, like happiness, loving sensations. Those are both would also meet mood symptoms requirements. Feelings of detachment, and similarly to major depressive disorder, a significant decrease in participation or interest in hobbies, time with family, or other significant activities in one's life. Criterion E are alterations in arousal, and these are something that really define PTSD, and are very important that this criterion is met. And this is marked when these arousal symptoms happen after the traumatic events occur. With mood, I forgot to say, they can either worsen or begin after the traumatic events. They could have already been happening, but have worsened now would be a marker of PTSD. But these changes in arousal have to happen after the traumatic events have occurred. And they can include things like self-destructive behavior, substance abuse, and gambling are not uncommon. Hypervigilance, some people will call this paranoia, but it's not really at paranoid levels, as we've discussed in this course. Hypervigilance for sure. Exaggerated startle response, outbursts, and irritable behavior that are out of character for the individual. Oftentimes they'll blame other people or get mad at them unreasonably. Having a hard time concentrating on your work, and also having a hard time falling asleep, staying asleep, or getting quality sleep. And that really can tie in with the nightmares that we discussed earlier. Can also be part of these sleep disturbances. So the rest of the criterion are kind of like stipulations, I like to think of them as, that help differentiate the previous symptoms that we've seen before from other disorders. Like acute stress response is very similar to PTSD, and these last three criterion really help define it as its own separate thing, which is really important in the treatment, which we'll get into in a moment. So criterion F is the duration of the disturbance, which would be the previous criteria except for criterion A. That would be all the symptoms have lasted for more than a month. Criterion G is the standard. It's a disorder if it causes you significant impairment in your life. And criterion H is independence, that these disturbances are attributed to the trauma and cannot be related to a medical condition or a different mental disorder. And those are all very important in classifying PTSD by itself. Alright, so how do we really diagnose PTSD? Let's look at it all at once. So PTSD is a trauma-related disorder that is characterized by the following behaviors, which are attributed to a traumatic event or traumatic events that either happened directly to the person they witnessed or they have heard about in detail to somebody that is very close to them. Also note that it's important that PTSD is classified and treated differently if you are under the age of 6 years. So the following that I'm addressing applies to the age group of those older than 6 years. So the symptoms that I just mentioned include intrusive thoughts, dreams, and dissociative reactions to cues that remind the person of the original traumatic events that they had. Sometimes these cues are very minor, and sometimes these intrusive symptoms happen without a cue at all. They avoid reminders or these cues of the traumatic event, and they will go to extreme lengths to fulfill this avoidance. Negative pattern of thought and mood, which share many symptoms of being in a depressed mood, but it's not quite the same thing. Irritability and outbursts of anger are often common. And alterations in physical arousal, a heightened flight or fight response when startled, and other physiological reactions. And what makes these set of symptoms be post-traumatic stress disorder instead of being attributed to a different mental disorder are the following criterion. First off, that these disturbances have lasted longer than a month. That is absolutely critical. That they cause significant distress in one's life, impairment in work, school, home, one or more major areas of one's life, or even just your overall level of happiness can be cause for it to be considered a disorder. And also that the symptoms cannot be attributed to a different mental disorder that the person might have. And again, very critical here that this is all related to a traumatic event or traumatic events that this person has experienced. So, that is what post-traumatic stress disorder is. Let's examine the causes and potential differential diagnoses that you need to be aware of when making a diagnosis. The cause is pretty obvious. It's caused by witnessing a traumatic event or traumatic events. However, that is just the onset of it. What causes post-traumatic stress disorder to continue and for these symptoms to last a month or longer, that make it post-traumatic stress disorder instead of acute stress response? There are a lot of genetic and environmental and social factors that go into play. Women are more likely to have post-traumatic stress disorder because they are at a higher risk for being the victims of rape and sexual assault, which are extremely traumatic events. Many men around the world in many different cultures do not have access or do not feel that they need to access psychiatric help after they've experienced traumatic events. And one of the number one indicators of whether or not somebody will develop post-traumatic stress disorder after they have witnessed or been victim to a traumatic event is whether or not they're able to process that trauma quickly after being exposed to it. So there are some cultural influences as well. For example, in many Asian countries, men expressing strong emotions in public is heavily frowned upon. So, men in countries with very traditional Asian culture might have higher rates of post-traumatic stress disorder. Also, older individuals are more vulnerable because they're more likely to experience social isolation and mental and physical stress from cognitive decline and the physical decline that are just natural parts of aging. So older individuals who experience traumatic events are at a greater risk for developing post-traumatic stress disorder. So let's make sure that we really understand how post-traumatic stress disorder is different from other potential diagnoses that we could make. So adjustment disorders share a lot of these symptoms, especially with the avoidance or erratic and out-of-character behaviors. However, post-traumatic stress disorder specifically says that it is a traumatic event. Somebody might have an adjustment disorder from an event that is not considered traumatic, like being fired from one's job, very stressful life event, but it would not be considered traumatic, so you wouldn't attribute PTSD to that. Acute stress disorder is very similar to post-traumatic stress disorder. However, the primary thing that sets them apart is acute stress disorder lasts between 3 days to a month, where post-traumatic stress disorder has to have the disturbances persist for a minimum of a month before a diagnosis can be made. Major depressive disorder, we see a lot of those shared symptoms such as negative emotions, difficulty experiencing positive emotions, avoidance, being withdrawn socially. However, major depressive disorder does not include the intrusive, or avoidance symptoms that PTSD does. Major depressive disorder also typically does not have any of the dissociative effects that PTSD potentially causes. Personality disorders share some symptoms, and somebody might actually meet the criteria for a personality disorder based on the way that their perceived personality to the people around them has changed, because people with post-traumatic stress disorder in their symptoms will act very differently when they're exposing them. And so, initially that might be considered for a personality disorder, but the thing that sets them apart is that personality disorders typically develop in late adolescence or early adulthood. And PTSD can occur at any stage of life. But the real thing that you have to note is that post-traumatic stress disorder is attributed to the traumatic event or traumatic events, absolutely critical, whereas the personality disorders are usually the result of poor parenting, poor upbringing, and other life stressors that happen to them in their development. They're not developmental disorders, but that is how they usually originate, and PTSD has a different origin. Dissociative disorders. PTSD does have some dissociative symptoms, but dissociative disorders don't frequently focus around one event, whereas the dissociative symptoms in PTSD will always relate that person back to the traumatic experiences that caused the PTSD to begin with. And they're specific like that, which is how it sets PTSD differently from them. Psychotic disorders. The presence of, what people commonly refer to as flashbacks, the hypervigilance that some people might call paranoia, look pretty similar to some psychotic disorders. However, PTSD is different because it's the result of trauma. And actually, in making a diagnosis of PTSD, it is very important to rule out the presence of schizophrenia, brief psychotic disorder, and other disorders that could have strong psychotic symptoms. And that's really important because those disorders really do look a lot like PTSD. And if you remember, one of the criterion of PTSD is that the symptoms cannot be attributed to a different possible. Alright, so those are the causes and potential differential diagnoses of PTSD. Let's examine now the prevalence and treatment of the disorder. So according to the DSM-5, the lifetime risk for U.S. adults is 8.7%, and the chance that any U.S. adult will develop it in the course of 12 months, or easier to say, the amount of people who will get it this year is about 3.5%. Different areas around the world have drastically lower PTSD rates. These include Europe, most of Asia, African and Latin countries, but other areas of the world that are particularly those who are experiencing civil war, prolonged fighting. Traumatic events are happening to average everyday citizens as the face of war becomes increasingly in urban setting. It puts citizens for those areas at greater risk because the traumatic events are happening to and around the citizens much more closely now. PTSD is most prevalent in the survivors of rape, military combat, and internment, which is to say prisoners of war, survivors of ethnically or politically motivated internment or genocide. That's what the DSM-5 says. We could put that as, more simply, as rape survivors, combat veterans, and those who have experienced or whose family have experienced events such as the Holocaust or the internment of Japanese Americans during World War II. And we see that PTSD even has the potential to occur in generations after this has happened, as we know that a possible stressor that causes the onset of PTSD can be hearing in detail about these traumatic events that have happened to a loved one. So somebody's grandchild could even get PTSD, potentially, from hearing in detail their experience as a Holocaust survivor, just for example. Which is something that does happen. Very unfortunate. So, like I mentioned earlier, because of the different risks that females are at, they are at a higher risk for PTSD because they're more likely to be victims of domestic abuse, rape, and other traumatic events. And yeah, we talked about the Civil War. Treatment for PTSD, well, primarily, medication can combat a lot of the symptoms. There are anti-anxiety medications for the hypervigilance and anxiety that individuals with PTSD occur. Antidepressants and mood stabilizers are all very effective in targeting some of these symptoms. Usually what will happen is the most severe symptoms of somebody who has PTSD will be targeted by medication. And then there are also particular medications that can be used for other symptoms, like it's possible to treat the night terrors and psychotic episodes that individuals with PTSD experience with medication. Probably the biggest and most important is cognitive behavioral therapy, because it can really help to, I don't want to say undo, but restructure the distorted patterns of thinking about the traumatic event, about the person themselves, and about likely unrelated things that this individual has come to attribute to be causes of the traumatic event or its consequences. Cognitive behavioral therapy is really going to help those individuals try to restructure their patterns of thought in a way that are a lot more healthy. And when we see them do this, a lot of the other symptoms begin to lessen or disappear. Also, prolonged exposure therapy can be very effective. And there are other forms of therapy. Group therapy is common in combat veterans who have post-traumatic stress disorder, and that is the most well-known form of therapy that individuals with PTSD do, although it's probably not even the most important. Cognitive behavioral therapy and prolonged exposure therapy are very important. If the individual's PTSD is causing them significant troubles in their family therapy is an excellent treatment option that the individual might want to consider. There's also eye movement desensitization and reprocessing, or EMDR, which is a pretty new, relatively speaking, treatment, and it involves having the person move their eyes quickly, which scientists think stimulates the brain in similar ways to rapid eye movement in the sleep. And this eye movement combined with somebody doing talk therapy with you, similar to cognitive behavioral therapy, really helps individuals process the trauma that caused all of these symptoms to begin with. This EMDR is very, very good for individuals with PTSD because it helps them address the cause of their PTSD at the direct source, the memories of this traumatic event that are causing all of these other symptoms. So it's not effective in everybody, but if it is, it's absolutely, shows great results. And there are novel treatments in development. You might have heard of MDMA being administered in a controlled setting, or certain hallucinogens. There's a lot of talk about these because it's interesting, but their effects have not been proven, and you should really be wary and really look closer at them because they're still very much in the very beginnings of trial phases, if that. And a lot of it is anecdotal. Just like there's a lot of anecdotal evidence that people who take LSD stop becoming depressed. The scientific evidence is really not there yet, so definitely be wary of these novel treatments that people are discussing. Public image and misconceptions about post-traumatic stress disorder. PTSD is pretty widely known. We've come a long way since World War I and World War II in understanding what happens to individuals who have PTSD. However, a lot of people still don't understand that it can be attributed to any sort of trauma, can cause PTSD. It is still widely known as like a soldier's disease, and although soldiers are one of the groups that, combat veterans are one of the groups who have PTSD most frequently, there are a lot of other people who get it, particularly police officers, paramedics, firefighters, other first responders whose work puts them at a high potential for witnessing traumatic events. Content reviewers that work for internet companies, they see a lot of horrible things, on the daily, unfortunately, and we thank them for that, for keeping, our platforms free of disturbing content, but they have PTSD pretty frequently from the images that they see. PTSD for quite a long time has kind of been seen as like as being caused by the individuals who have it being weak or not being able to process trauma because they had an easy upbringing. As we discussed in the causes, that's not really true at all. A lot of it has to do with how early on they process the trauma, and whether or not traumatic events happen just once or reoccur to them. When traumatic events are recurrent, they are far more likely to be very damaging to the individual, and to potentially cause acute stress response, or if the symptoms persist longer than a month, post-traumatic stress disorder. PTSD is also seen in war movies more and more, and it is often misrepresented. There are many scenes where an antagonist is having a flashback, so the movie says, and they can't differentiate their surroundings, and they think that they're in a war zone again. That kind of dissociation doesn't happen regularly at all. It's extremely rare. And the dissociative symptoms of PTSD are not even as common as the mood disorders and the avoidance symptoms. Those are much bigger threats and need to be taken very seriously, even though they're not portrayed in the same way. And widespread media, which affects public opinion and conventional wisdom, unfortunately. Many people don't believe that PTSD gets better. They think it's just something that happens to soldiers and they live like that. The DSM-5 was stating that I believe it was more than 1/3 of individuals who are diagnosed with PTSD make a recovery in 3 months, which is excellent. Unfortunately, it is true that it can persist for more than a year or even decades, but that kind of extremely long-term PTSD is a lot less common. Most individuals who are diagnosed with PTSD make full recoveries, which is fantastic. Flashbacks and triggers, as they're commonly known, and trouble sleeping are probably the most well-known symptoms of post-traumatic stress disorder in the public eye. But difficulty in interpersonal relationships, your family, your work, depressed mood, withdrawing from social activities, and the hypervigilance and blaming oneself, these altered patterns of perception and thought are probably the most concerning symptoms of PTSD that really cause the most harm to the individuals who have it. Let's go over some quick misconceptions. We kind of already touched on some of these before, but we're going to go through them again anyway. PTSD is exclusive to combat veterans. Not true at all. PTSD can affect anybody who has undergone a traumatic experience, witnessed somebody else undergo a traumatic event or events. This can be a repetitive thing, or even heard in great detail traumatic events that have happened to a loved one. Can happen to anybody at any stage of life. Even though it may be more common when you're older, it can occur at any stage of life. Myth 2. Those who experienced extreme trauma always get PTSD. This is not true at all. We talked about those environmental factors that alter whether the likelihood that somebody who has been exposed to a traumatic event will get PTSD. There are also genetic factors that have been isolated and confirmed to exist. Also possible, you might get acute stress response after witnessing a traumatic event, which is different than post-traumatic stress disorder, but the two are very commonly confused in the public eye. Myth 3, people with PTSD are dangerous. This is not really true. Violent behaviors are not typical in individuals with PTSD. They may be aggressive, angry, oftentimes because they're fearful, or they might just be angry. That's one of the depressed moods or negative moods that we talked about in mood symptoms. Physical aggression may be a symptom, but patterns of violence in individuals with PTSD are very rare. They're no more dangerous than anybody else, mental disorder or not. Myth 4, people with PTSD are weak. Very, very not true. As we discussed, PTSD can happen to anybody at any stage of life after witnessing or being involved in a traumatic event. And the genetic, cultural, social factors that go into whether or not somebody is going to develop PTSD after being exposed to a traumatic event are very, very often out of the control of the individual. So it really does not say anything about how weak or strong mentally the individuals who have PTSD are. It's just not true. So, this scene in Avengers Endgame is actually a very good portrayal of PTSD. I'm not going to play it here, but it is included in the PowerPoint, the same PowerPoint that I've included. So I encourage you to watch it. But before you do so, I'll give you some background information on it. So, in this scene, two characters, Professor Hulk and Rocket the Raccoon, go to meet a friend that they haven't seen in 6 months. His name is Thor, and 6 months ago, all of them together witnessed a series of very traumatic events in a previous movie, and they are going to go get Thor to try to undo some of the harm that has happened to them. So, go ahead, take a moment to watch that scene. It's very good. Okay, so Rocket and Hulk find Thor, and he is engaging very obviously in self-destructive behaviors. Previous to this scene, he was only seen as a very muscular and fit person, and you can see now that he's gained quite a bit of weight. He is not participating in healthy eating or exercise habits, and it's very apparent that he is abusing alcohol, or at the very least drinking more than he should. That is very present in this scene, and those are some pretty marked symptoms, self-destructive behaviors of PTSD. Additionally, you can see that he is in a more depressed mood, even though he kind of tries to hide it. As soon as Thanos, who is the person that caused these traumatic events, is mentioned, you can see his mood instantly change. And he goes on to say that we don't say that name in his house, which is clearly an avoidance symptom. Very extreme, and to not even be allowed to say that name around him. Because, and you can see change on his face, he very much is taken back to those traumatic memories. So that is definitely a cue that he is avoiding. Additionally, you can he's become a more disillusioned, kind of pessimistic person, which are changes in his personality that are not normal for him. He, in fact, even gets aggressive towards these people who are his dear friends, and these aggressive outbursts are another symptom of PTSD. So we can pretty soundly conclude that Thor has post-traumatic stress syndrome. And in this scene, I think it actually portrays it very well. I think that it is actually an excellent representation and sheds a lot of light on the disorder in a way that we don't normally see in popular media. However, not pictured in this scene are the problems that I have with the way that post-traumatic stress disorder is addressed in this same movie. Later on, Thor goes on to reunite with his friends, a lot of whom make jokes at him for the way that his body looks now, for the lack of his confidence, and for the way that he avoids talking about these things that are causing him so much pain. And I think that is absolutely terrible. I think that that is completely victim-blaming people with mental disorders, and I find it rather disappointing that this scene that portrayed PTSD so well is followed up by essentially making fun of somebody with a serious mental disorder that isn't their fault at all. I also forgot to mention that Thor blames himself primarily, you see in later scenes. Even though that's not true, he did the very best that he could, and that is an example of the distorted patterns of thinking that are common in PTSD. So, overall, I think not the best job. That scene was pretty good, but it was very disappointing to see, stigmatism around PTSD continue in popular media. So finally, I would like to conclude this presentation posing this discussion question. What do you think are some of the biggest challenges treatment poses to individuals with PTSD? Do you think getting comfortable with cues that remind them of the memory must be pretty difficult in their modern lives, balancing medications, taking them, having to admit to friends and family that they have a problem could be challenging. Processing the trauma itself, I think, would perhaps be the most difficult part, or even reintegrating back into your life in school, work, or home once you've started to make a recovery and build up those interpersonal relationships again could be a real challenge. But that's an excellent discussion question. This concludes my presentation. Thank you.